Radha ma'am, I think you're muted. Dr. Radha?
Ma'am, we can't hear you. You are muted, I think.
Now I've unmuted. Just give me a minute. We'll get back to the... Just a minute. Is the presentation seen now?
Yes, ma'am. Like it is visible in big screen, but I believe, yeah, now it's good to go.
Now is it full screen?
Yes, ma'am, good to go.
Okay. 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 First, we'll start off with the definition. The International Association for Study of Pain had given a definition. But after 1979, even though it's been many years, they had a full slight redefinition or slightly tweaking the definition in 2020 July, in which they have added few important keynote features, which are essential both to understand, assess, and treat pain. So we will see what is the current 2020 tweaked definition. What is it? What is the definition of pain? It is an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage, and is expanded upon by the addition of 6 keynotes and the etymology of the word pain. See, in this definition, every word is important, whether it could be actual or potential tissue damage, and the added features, it is an unpleasant sensory emotional experience. It's just not a nociceptive injury that message convey. It is just not that. So that is the important thing to understand. So every word in this definition counts. Now we will come to the 6 important features, which the added features. Pain is always a personal experience. What do they mean by that? What they're trying to convey that it could be influenced by varying degrees of biological, social, psychological factors, which are important. Next, pain and nociception have to be clearly understood. In the next few slides, we will see in detail what it is. Next, life experiences do have a role. See, when one person has that incidence of pain, what was that connected to? So were they in a very low mood or something like that? So every incidence at the time of the pain happening has a role to play. Then expression of pain needs to be respected. So just we can't say, oh, you are imagining, something like that we can't say, because now by the end of this session, you will be able to understand why I am specifically telling that. So respecting someone who says, because it's a personal and subjective experience, so it has to be respected. And next, pain usually is said to have an adaptive, but may have an adverse effect too. Because of pain only, we are able to identify and do things, but that itself can be an adverse phenomenon. That also we will see during the course of the session, why it is said so. And last but not the least, verbal expression is not the only way to express pain. It is one of the ways. So verbal expression is one way of expressing pain. See, for example, for this, normally we say a patient in ICU does have pain and he's unable to talk or say, but still we can find out. There are factors and features for it, which also we will see in due course. So these 6 features which they've added on are very important, as I mentioned, both for assessment of pain and treatment of pain and understanding pain also. So everything is essentially important. Next, whenever we say something about pain or describing pain, we add on these factors. Where is the pain? That's the site of pain. How is the pain? Sharp, throbbing, different types we say. And next, extent. Oh, from where to where? It is from this point to that point. So that is also important. That gives you an idea underlying where from the pain is coming. Next, important, aggravating and relieving factors. Oh, when I do this, I feel better. Oh, I don't, whereas it is not so with something else. So they are also important to obtain from history. And last, whether that pain is impinging your daily routine, whether it's impinging your sleep. So everything is essential. So these elements we get from the history. So it may sound simple, but by getting all the information, your diagnosis or clinching the diagnosis will be definite and specific too. This is next is a diagrammatic representation of what is pain, and this physiology and pathophysiology, all of you know, but just with a diagrammatic representation, we will get a quick idea. See, from the picture, you can see it. You have nociceptive information coming from the periphery. That again can be of various types. It could be, if it is from the skin, it is thermal. If it is from the joint, it is mechanical stress. If it is from visceral organs, it is conveyed through mechanical distension. And in muscles, you have mechanical strenuous exertion, which conveys the message. And above all, there are the involvement of chemical mediators in conveying any information from the periphery. Then you have the sensory nerves, you have the spinal cord, and in the spinal cord, dorsal horn is an important area. Then you have the ascending fibers. Ascending fibers, you know, spinothalamic tract crosses over, and then you have tracts which don't cross over. They all go to the brain, where you have the thalamus, all brain representation of various areas. Then you have the descending tract. Descending pathway is equally important because it conveys, and it also has an inhibitory role, which we will also see in due course, because that is also important in understanding and treatment. So, and then finally, the message is conveyed back, and that is how it is perceived. So this is just a quick diagrammatic representation. Next comes, what is the difference between nociception and what is pain? Nociception. Nociception refers to the detection of noxious stimuli by nociceptors. Then it is conveyed by transduction, transmission to the sensory nervous information from periphery to the brain, which we have seen now. What is pain? Pain refers to the product of higher brain center processing. It entails the actual unpleasant emotional and sensory experience generated from the nervous signals. Okay, so this difference is what is mentioned in one of the 6 keynote features. Next, we'll come into the pathophysiology of pain. The mechanism by which the damaging stimulus in the body is perceived as pain by brain is a complex one. Then what is the complexity? The complexity of the process results because of the nervous system is not being a hardwired system. See, it is tricky. It doesn't have only one particular response. It is smart. That's why. So, but by exhibiting plasticity, that enables it to modify its function under different conditions. So basically, plus and minus are there for everything. So if it is hardwired, only 1, 2 plus 2, 4, 1. So no, not much involved. But being plastic, there is advantage and disadvantage. That is where, if you understand and treat, you get the best benefit out of it. Pain, generally, next, pain serves the purpose to prevent tissue damage, as we saw before. But under certain conditions, the pain can become maladaptive and persist as chronic pain. When this happens, when there is no protective function but becomes a pathology, it is a disease on its own. This is the important take-home message, I would say. As long, see, it has its own plus of conveying the message. But when this neuroplasticity and varied responses come into play, that is when the disease element comes into play too. And what is neuroplasticity? This is another factor to be understood well. It is the capacity of neurons and neural networks in the brain to change their connections and behavior in response to new information, sensory stimulation, development, damage, or dysfunction. So everywhere. So this is how this neuropathic pain and things which we will see in due course, all these play a role, and how they play a role also we will see. Next, we'll see, as we have seen, what are the modulations that happen. The various neuromodulation or the pain modulation mechanisms. First is peripheral sensitization. What are they trying to mention in this peripheral sensitization? Is that whenever there is tissue injury, we have seen that there is inflammation. Next, when the inflammation happens, inflammatory mediators are released. And at that time, arachidonic acid metabolism takes place, and that leads to release of interleukins and prostaglandins. And this can just, at the site of injury, they might be released, but there may be further release also happening. So the whole event is called as inflammatory soup. And that inflammatory soup may be in that area, but it can spread to surrounding areas also. And that is one of the reasons for secondary pain. So the inflammatory soup which happens, that itself aggravates and it surrounds to the nearby areas. And by surrounding that, it can recruit some nociceptors which were dormant. They can also be triggered. So that is why this peripheral sensitization is important. And by what I've explained, that is the mechanism by which it aggravates or increases. Next, central sensitization. What is central sensitization? That is, there's an increase in the excitability of the dorsal horn, so that the dorsal horn cells have a lower threshold and respond to low intensity stimuli that are not usually painful. So we saw first peripheral one, next central one. Central one, even a low threshold pain is triggered. That is because of the central sensitization. Then comes the neuropathic pain. Neuropathic pain again arises normally following diseases or injury to nerves from number of etiologies. And these are very common ones: ischemia, trauma, infection. Diabetes mellitus is a very common entity, which all of you know. You have a polyneuropathy, and which have polyneuropathy, peripheral neuropathy, everything happens. So that is one common example for this. Next, we'll see a little bit into the peripheral mechanisms by which neuropathic pain. First is spontaneous ectopic discharge. What happens? It self-fires. So, and because of that, already the same inflammatory soup, everything's there. But because of this capacity to self-fire, the intensity or the occurrence is increased, and ectopic firing is a common cause for that. Next is altered gene expression. In that front, the Wallerian degeneration is said to happen, and that changes, it causes change in the type and level of neurotransmitters released. So there could be an upregulation or downregulation happening because of that. So that is another entity. And involvement of the sympathetic nervous system also happens when there is neuropathic pain. So areas which are adjacent to the site of injury. So the sympathetic system which is nearby also gets involved. Commonly what we would say is CRPS and things. It is just not the sensory, sympathetic. You will have symptoms of sudden warmth or sudden cold, and then there may be edema, shiny nature. All those things are sympathetic element which are also added on with the sensory element. So involvement of the sympathetic also happens. And then collateral sprouting can also happen. That is also said to be another mechanism by which the aggravation. This common examples are crush injuries and stump pain, those type of things. Those are the examples for that. Next, central sensitization in the from neuropathic element would be the central mechanisms potentially involved in the generation of neuropathic pain are thought to result in neuroplastic changes, which we have seen before. So what are the central sensitization mechanisms next? Common are wind up and central sensitization. Wind up, and basically it is an amplification of the response. If you understand the word amplification, what is amplification? It is making something small into big. So that is what happens. It could be of two types. It could be a wind-up mechanism or a central sensitization. Both of them are amplification only. But wind-up is a short-lived phenomenon, whereas central sensitization, if it happens, that is a long-lasting phenomenon. And just this is some basic understanding to understand the gate control theory, and also commonly whenever somebody falls, we rub on the area. Those type of mechanisms, how do they reduce the pain? This is mainly by the descending tract mechanism. So if you see these two pictures, the picture on the left, the pain is conveyed only through the C fibers. So the pain is perceived. If you see in that picture, you have the AB. The AB is the fiber which carries the touch sensation. That's why by rubbing and all those things, so that and the inhibitory pathway are not stimulated in that. So the pain is perceived. If you see the diagram on the right side, all of them are open. So basically, whenever there is pain, if you rub, or this is the same mechanism used for TENS machines also. So you use that, you stimulate that AB fiber also, it takes away the pain. So this is a diagrammatic representation to understand very well what is gate control theory, because this part is mainly for understanding the pathophysiology and how it works. And this is the key thing to be understood to treat pain also. Okay. Next, this is another diagrammatic representation of various levels. What we have studied is used in the management of pain. So like from the skin, if you go, the local anesthetic drugs, how they act at the periphery. And then you have drugs which act on the dorsal horn. And then you have drugs which act on the central nerves. So this is basically a diagrammatic representation of both understanding the pathophysiology and at each level where drugs are used to help in management. Next, we come to the types of pain. What are the types of pain? It could be in various types. It could be acute pain or chronic pain. Acute pain is one that is present at the site of injury mediated by nociceptors, and it is short-lived. Chronic pain is related to pain in conditions such as diabetes, arthritis, tumor growths, etc. Anything which has lasted for longer, more than few weeks to months, then it becomes chronic. Then we have somatic pain, which is generated in the deeper tissues. Visceral pain, which is there from the gastrointestinal tract, which we mentioned earlier, due to mechanical distension. Then you have the neuropathic pain caused by damage to nerves, resulting in increased firing, etc. And then the next three, what I mentioned, are like symptoms which convey these type of chronic pain. Allodynia. What is allodynia? Allodynia is pain resulting from a harmless stimulus. Normally, that stimulus doesn't cause pain. Common example, I would say, when you see people who have chronic pain, touch, they say touch causes pain. Normally, touch doesn't cause pain. Otherwise, we wouldn't be doing handshakes. So that is mainly due to the neuroplasticity, all what we have seen. So because of ectopic firing, increase, the threshold is reduced. So all those what we saw before is the cause for allodynia. But what is allodynia is what you need to understand. And when you see patients, they would say, commonly what is said is their own dress. For example, if they have some neuropathic element pain in the knee, the dress touching their knee, they would say, any cloth touching their knee, they could say it causes pain. Or even our own touch, patient's touch. Oh, coincidentally, I just rubbed my hand over that area and it hurts. So that is a common way how allodynia. And hyperalgesia is exaggerated response to normal stimulus. For example, something should not cause pain, maybe causing a pain symptom. That is what it is. Referred pain is pain felt in other areas. So common is myocardial infarction. I mean, all of us know. even though it's pain in the chest, but pain in the left arm or throat or something could also be myocardial infarction. And similarly, commonly nowadays, we do a lot of laparoscopic surgeries. So from that point of view, what I would say, anyone who has had a laparoscopic procedure, they may complain of shoulder pain. That is because of the air under the diaphragm. And that is another common example for you to understand what is referred pain. Next comes assessment of pain. Why is assessment of pain important? That is important in few ways. It is a valid and reliable assessment of pain is essential for both clinical trials and effective pain management. For us to know, understand, and study, keep on studying, keep on doing more research, also we need assessment. At the same time, to effectively manage it, we do need to have proper assessment. Next, acute and chronic pain assessment has to be done in its own entirety, because we have seen both are different. And they have certain salient features which have to be picked up to diagnose and treat. Next, a little bit information of what are the types of assessment. For acute pain, you have the numerical rating scale, you have the visual analog rating scale, the dynamic pain assessment. That is important because sometimes they say, why I don't have any pain when I'm sitting. Only when I start to walk, I have pain. So everything, every part of it is important. Then you have the baseline pain assessment. From chronic pain point of view, it's multidimensional. So every element of it has to be assessed. So it has to be a qualitative tool. You have several disease and patient-specific scales for it. And you have neuropathic pain assessment inventories, many. And each area and hospital have their own, and it is always best to stick to what you use. Because first to familiarize with what is used in the place, because always tailor making to the needs and the area where we are working. These are some basic guidelines. Then you tailor make to what is your need and work around, because that is the way forward to be the best in assessment and providing the best care to the patient. So here we have the numerical rating scale and the visual and the all represented in one. So basically, nowadays, most of the patients, we say if 0 is no pain and 10 is maximum pain, where would you put it? Or you can say, if okay, they say number is not fine. So then whether it is mild, moderate, severe. So all those type of things, gradation, basically, we try to explain and get the information, what is convenient and comfortable for them. And you also have the pictorial representation. This is another one. And what is on the screen is another chart which is very helpful, because see, sometimes they may, communication is an important thing. Language barriers, or sometimes understanding or things, different demographics, different educational status, so many things are there. So this is a very simple and clear way of getting information. So in this, you can give this and then ask them to mark where is your pain, from where to where, and things like that. So they'll be able to depict and convey better. So this is another chart which could be used. And then we come to the chronic pain tools. We have the brief pain inventory, which is said to comprise everything. And you have the Megal pain questionnaires. See, basically in these type of things, what is the additional? Here you will have little bit of emotional, sensory element. And then for each factor, we'll ask whether that each one is moderate, severe, or mild. And you want to say, oh, this is nature of the pain. So these are all slightly elaborate ones. So that is why you have a detailed form and a short form. So 10 to 15 factors are considered in that. And then in each factor, you will have gradation. So we are going into in-depth, because the chronic element is just, as we have seen, it has the emotional sensory. So even you can have their mood assessment. And whether you can ask quality of life factors are also added to this. Because as I said, whether it is impinging your life, whether it's impinging your sleep. So the chronic pain assessment tools are a bit elaborate, and they have to be patient-specific, disease-specific. See, for example, if you take diabetes, we need to know what is the control of diabetes, because from diabetes point of view, one golden statement, it all depends on how good their glucose control is. If the glucose control is not good, the pain control will never be good, because there is a very clear evidence-based information which says the glucose control, if it is not kept to mark, the pain relief will never be good. So like that, when you're going to see a diabetic patient, means you have to get to know more about that also, because you may be thinking, oh, I'm giving everything, why is it not controlling at all? Maybe their blood glucose levels are 400, HbA1c is always about 10. So something like that is also need to be considered. Next comes cancer pain assessment. Major impact on cancer-related pain management happened after WHO guidelines in 1986, but still globally, pain relief of cancer is far from satisfactory. Mainly why they say that they contributed to the availability of analgesic drugs. Still, either the drug itself is not available or drugs are available, but reaching or taking the drug to the patient or delivery of drugs to the remote areas. So still globally, that is a big issue which is being met. So regarding cancer pain assessment, the Edmonton system assessment is one of the important recognized one. And in that what is the difference between other pain and this? See the factors which I have mentioned below. So pain and shortness of breath are set to form a big chunk. Apart from that, so that for that control, we have systems in place and medication. So that covers a bigger part, but other factors, activity, nausea. See, activity, oh, I'm on, because they're so weak and frail, they're unable to do anything. So we have to encourage them how to overcome that. Then activity, less activity and depression, anxiety, all that are interrelated. So by slowly teaching them or telling them, this is how it will be, but you can do, see, for example, I told you, no activity. So you can tell them simply sit, stand. That's a common thing called for very, very frail. There's something like sit, stand exercise. You can just tell them, don't worry, you can't do anything. In 1 hour, do sit, stand 1 or 2 times when you can. Or them. So these are the type of encouragement which we have to give for them. So by doing that, activity, depression, anxiety, all those 3 can be covered. So next is appetite. Nausea, appetite is another very, very important hardship which those type of patients have. So we have to tell them, maybe you normally are used to eating 2 meals, big, large, but that may not be possible. Small, frequent meals is something you have to adapt to. So because energy is needed. If you don't eat, then again, this activity, it's a cyclical phenomenon. So these are all very, very important. If you do all that, then the well-being will naturally, gradually improve. See, we are doing everything in patient's best interest. So we have to see how can I deal and help them. So these are the important factors. These may be very trivial for somebody else, but these are the cornerstone or important factors for patients with debilitating diseases. Okay, so those are the things. So there are other specific assessment tools also for patients like this, as I mentioned, disease specific, dementia, something they cannot convey at all. So how are we going to do? So there are specific tools for all these type of things. And so overall, the understanding of what is pain is important. If you understand that first and then go ahead to assessment, then diagnose, and then management will definitely be good. So understanding that it is just not simple. It has got all these elements. Don't think that, oh, it's complicated. Oh, it's not one step. It has got multiple factors. If I put everything together, then I will be able to come to a diagnosis. So that is why the understanding of pain is equally important to help us to diagnose and treat effectively. Thank you, one and all.
Thank you, ma'am. Thank you so much. There are a few questions in the chat.
Oh, just I'll stop sharing and in a minute.
Yes.
Okay, we'll see what is in the chat.
Can you see it, ma'am? The chat?
Yes. That's what I'm just starting.
Okay.
The thing is that first one is the one from Paul or Paru. They basically, see, that's why, see, noxious stimulus, there the neuropathic element is what is. Noxious stimulus, not that there was no noxious stimulus. Either it could be a physical injury or it could be this ischemia infection could be the cause. So that is where, so this not identifying, when it has become chronic, you have to start thinking what are the possibilities. That is where the expertise comes, and everything is there. So we have to find out what are the problems. Okay, there is specific, maybe the page from the question that you've asked, no noxious stimulus. Either if there was no noxious stimulus, it could be possible. If there is diabetes, you need not have a noxious stimulus. So diabetes is the noxious stimulus. So that is, so could be causes. So that is why a detailed history is very, very essential. Okay. And next, your question between allodynia, hyperalgesia. See, allodynia is, as I said, normal, common, as I said, touch causing pain. Hyperalgesia is exaggerated pain. See, these are all adjectives. Okay, so you have to, there will only be a fine line between these two. But these are the common symptoms of neuropathic pain. So if there is pain to touch, it could be called as allodynia. And if it is exaggerated pain, so see, if you really keep on prodding into that, you can come and say, oh, both are same. But these are the common things. Allodynia, there is normally, where there's normal, that's symptom or something. For example, touch shouldn't cause pain. But when that causes pain, it is just the basis is neuroplasticity is what is causing all this.
There's a question on neuroplasticity. Explain neuroplasticity in terms of pain.
See, neuroplasticity, basically what is neuroplasticity? It is not hardwired or one way. So for example, what you asked, the cause was in one side. So where the injury happened alone, I should have pain. But it has not stood like that. The injury happened, the surrounding area has aggravated or increased, then it has emotional, personal experience. See, normally this is why the whole thing has become a chronic issue itself. So that is neuroplasticity. The wind up, the peripheral sensitization, central sensitization, all that happening is neuroplasticity. So basically, it is just not one injury, one pain. See, for example, back pain or anything, someone has a fall when they are 15-year-old. Okay. But they have back pain all their life. In that element, so where the emotional, personal experience, everything has had a role. And furthermore, there is a lot of evidence to say the emotional element in the brain, that representation, and these neuroplastic elements which happen, they are so interrelated. So if someone is in low mood, their pain will always be high. So these are all used in the treatment of pain. So that is what neuroplasticity. It is just not one factor involved. Because see, the emotional, sensory element and all, they have a larger area and they have different ways. The emotion, if you take each person, their personal experience, their cultural element, everything has a role in emotion. Someone may be strong-willed, someone may be poor-willed. Why? Oh, this is how I was brought up. So like that, there are so many cultural elements, regional elements, everything. So that is what is neuroplasticity. It is not something simple. So that is why so much of element and information has gone into understanding this. It is just not, as I said, the diagrammatic representation just from the nerve point. It's just not a simple arc. Okay, as we would have studied beginning for a knee-jerk response, it is just not simple. So when it goes on to chronic pain, it has got so many other elements which have multiple bifurcations. So if you take the sensory and emotional element, you can do thesis on sensory emotional element itself. So that is why it is complex. Okay, and then what is the next?
I think which is better tool to scale the pain in cancer?
And you have scaling one, like if you just follow just a normal numerical rating scale is fine. From any chronic pain assessment, first assessment, reassessment, review assessment, that is what is important. Okay. For example, any form, that is why in my presentation itself, I said, don't take only this. What is used in your hospital is equally the best. Okay. You are using that, you're treating patient, you're getting benefit. Why do you have doubt in yourself? So whatever you use, fine. So basically assess, then go back, reassess. So assess and then start some form of management, medical management, non-pharmacology management, anything you start. Then only thing, regular reassessment. Initial phase when you're seeing, you have to see the patient, either see them personally or do a phone call, something in 15 days. Next, if there's because you can't just leave them, oh, I've given you something, come after 3 months. It will never work. So you have to reassess first according to each place's availability of resources. So as I said, sometimes you can't, for example, why I'm telling all this wall, what we used in Cancer Institute, where we used to see 50 to 60 patients every day. This is outpatient only, I'm telling. So we used to have a phone also. I will see patients and I'll have a phone service. They can call me that 9 to 5 when I'm there. I will see patients and they can call, like, for example, if I've seen someone 2 weeks time, they can call and tell, oh, yes, I'm following, but with, I'm getting 50% relief. So then I can either increase the dose, increase frequency, something can be done. So now 2 weeks, 4 weeks, 6 weeks, you have to reassess them. At that reassessment, again, you're going back to your pain scale, whatever you've used. So if it has come down from 10 to 8 or 8 to 2, so 8 to 2, very good. Or 8 to 6, okay, it's only some alteration, titration in the dose is needed. So that is how. So assessment, any assessment, numerical rating, because that you have to consider depending on your patient. What patient you're getting? A patient who can understand everything, fine. You're getting a patient who is not going to understand. We have to treat everyone, so we have to be accommodative. Okay, so any tool you use can be efficient. It's all in our hands. We have to learn and train and be efficient to help the patient. What are the other things? Any specific scale in there? For infants, even last time when somebody asked, this pediatric entity is a tricky bit. Okay, in that point of view, the child and the mother together you have to see, because more than us, the mother will be able to say what are the changes in the child's habits, whether the child is not eating, not playing. So like that, it is the assessment of pain in children has to be a separate entity, and it has to be done by the like with little bit more assistance from the pediatric team. And as I said, you have to always you assess with the mother. Mother will be able to give you more information. So those type of things are essential. There are many situations where patients. See, in that question, Roshan Kumar, no, that will go into details of management of pain. Just analgesic, adjuvant. There are so many other things. WHO ladder, that will be dealt in your next 2 sessions. Is that right, Sridevi? I think that is what will be covered in that.
There is a question from Dr. Usharani asking whether mentally strong person
See,
Having
yes, see,
high
that,
will.
see, that is, again, each one of us have a different threshold. So that is why, see, for example, for everything, see, God's grace, working this all over the world has been, for example, all of you know, any pain, just a tramadol, Ultraset, what you use commonly. In India, when I practiced, 2-4 Ultraset, they'll be fine. Whereas here, I've seen patients for whom I would have given morphine, 200, because there are so many, in that also so many elements are there. What is your gender? Are you opioid naive? What type of lifestyle you have? What is your requirement, kilograms body weight? So everything has a role. And mentally strong people, their threshold itself will be high. For example, daily, day to day, there are so many people who swallow paracetamol every day, 2-3 times headache. There are some people who don't go near paracetamol at all. So there are so many variations. We are all made different. Why? Because it will be boring if all of us would be same, and life will be easy for us as doctors. Because it's not so only is the challenge. So everything has to be taken in a nice way. And yes, mentally strong people, they may not need large amount of analgesics at all. So for example, you will see that when you see patients, even like, for example, I would say, you're seeing a 75, 80-year-old, stage 3, stage 4 disease or something. They may just be taking 2 Ultraset and they'll be fine. But the same one, somebody else may be needing morphine 10 milligram 4 times a day. So the individual variations are there, and we have to understand that as we see patients and move forward.
I think how to assess pain in unconscious patients or patients on ventilator is another question.
Yes, this is what I tried mentioning before. See, that's also possible. There you will have to put into consideration vital signs, heart rate, blood pressure. For example, ICU means you will have arterial trace, all those things on. So those are physical parameters. Then you have tears. Then you have response from them. All that can be done in intensive care patients, because see, just for you can ask them to grip our hands or some, if they are, see, even nowadays, see, even in intensive care, things have changed loads and loads to what it was before. We don't use muscle relaxants continuously. Those things are all outdated. So no patient is completely paralyzed or anything. We only ventilate them with the strong opioids, like you have a fentanyl or some infusion at low dose running, or you may have a propofol or midazolam. So they're not completely paralyzed at all nowadays. And also you have such good ventilators, you have assist ventilation. So CPAP, IPAP and all are there now. So what I'm trying to say is they're not completely paralyzed. So they themselves are better responsive. And even in that, tears is something which, if they are in more pain, you can see. And then vital parameters go hand in hand with the intensity of pain. So pain scoring, if you see any ICU chart, all that are always there. So from that point of view, I've done intensive care all along. So that is something which will be very, very helpful for you. So there are ways of identifying that also in ventilated patients. Anything else in the chat? Let me have a look. Psychiatric patients. 1 minute. Critical care, pain observation tool and physiological. See, psychiatric patients, again, it has to be individually what type of disease and everything has to be considered. And then it has to be taken into consideration. Complete assessment. See, multidisciplinary approach. You are having difficulty. Maybe if possible, you get resource from them. So that would be for psychiatric. And then are we judging someone's chronic pain by thinking whether that was, see, this is one element. You're not you're not going to give 100% only for that mentally strong. See, as I said, from this whole 30, 40 minutes is what? It is not one thing. It is multiple factors. You are those six factors. It is one of the factors. You're not just going to give weightage to that and leave all the important things. Or you will take just the mentally strong and leave his diabetes treatment, leave anything else. No, not at all. First thing to take home, give equal importance for everything. Don't pick on to something which is trivial and then lose the boat. Leave the important factors. It is not so. Give equal, that's what, again and again, don't label them by one thing and leave all the rest off. So give equal importance to everything, identify everything, use that to diagnose, and then use that to treat. So, okay, if there is a mentally strong person, okay, one point I will check. What for? Once I've done all the diagnosis management, so I will use that in his pain management. Oh, you're mentally strong. So why don't you have some pattern? You follow this regime. You take this. Every day you have a regular set pattern. You can stick to that and try doing exercises little by little, improve. There I will use this mentally strong character or nature. That is what we all have to, we are all already smart, dears. We are all capable of doing something. That is why we have come to this stage. So utilize that and shine further. Don't lose your boat in any point of time. So this thing of pediatric, psychiatric and all, these, I know they are challenging situations. So fine. See, we cannot be expert in everything. If not, why do we need so many specialists? We have all the advantages. Why don't we use? Only thing, resource limiting is the important factor. Every place may not have every specialist. Okay? So there comes the challenge. So how am I going to manage that? Okay, I don't have a psychiatrist. Will I be able to get a psychologist? To what stage I can help? Then psychiatrist, where is the nearest? See, mostly if it is a psychiatric patient, they will be having their regular psychiatrist. They are not going to come to it. And it's not an issue which has cropped up now. It would have been for 10, 20 years. So they will always be having a psychiatrist. So, okay, the patient can't go. You can send the family, find out. This is the information, sort out. So, see, where there is a will, there is a way. So we have to think a little bit out of the box. How am I going to solve it? How can I solve it? Oh, fine, you will find a way to solve it. So, and always getting assistance will help you definitely.
Thank you so much, ma'am. There were a lot of questions to you, but yeah,
good. See,
the questions are answered.
This chart is helpful and some feel comfortable. Hope everything is answered.
If there are any questions unanswered, we can take it up, or we can move on to the case presentation, and then maybe we can take discussion after that.
Dr. Kavish?
Hello, good evening. We'll start with, it is a case of a 70-year female patient with trigeminal neuralgia. Patient came with complaint of severe pain on the left half of the face since 2 years. Patient had an history of extraction of first premolar from the left side 2 years ago due to dental caries, after which she developed excruciating pain. Initially, the pain was less, but then it keeps on increasing with time, and gradually it spread over the entire left half of the face. The gradually then patient was initially was able to speak and eat everything, but with increasing pain, the patient was not able to open the mouth. So the food intake had decreased, which also due to which the patient was on liquid diet since last 3 to 4 months, which has also decreased with the increase in pain. And due to that pain, patient was not even able to talk in the family or around. And that pain was so severe that patient was, instead of speaking, she only used to cry whenever the patient came. On examination, patient was conscious, vitally stable. The investigation was done and all investigations were within normal limit. However, the weight of the patient has decreased over a year, as she said. Patient has consulted a neurophysician regarding the same, and patient was kept on multiple oral medications, carbamazepine, gabapentin, pregabalin, everything was started, but there was no relief was given to the patient. And patient was a widow. With decrease in weight, the patient has developed malnourishment. She was also a bit depressed that how will I go further with this? I'm not able to eat. I cannot talk. Nobody listens to me. And nothing. No improvement is seen in me, and that led to a fear of being left out from the family and society in her. So the main concerns here become is to elevate that pain so that patient is able to regain her food and regular habits of talking. That will, the elevation of the pain is going to be the main thing which is going to help with the patient. Additionally, the nutritional buildup and the emotional support to this patient of being a widow and knowledge that she is not alone in this situation, and we can help her out in elevating the pain emotionally as well as the physical pain. It is a case of a 70-year-old widow with trigeminal neuralgia who is depressed and malnourished also. So how should we go about the pain management of this patient? That I would like to.
I'd like to ask the participants who are there with you, what do they think about, we are not touching upon the management part because we'll be covering that in the coming sessions. In two, 3 sessions, we'll be focusing mostly on pain management, the upcoming 3 sessions and plus an additional session towards the end. But maybe what I was thinking when I went through this presentation, heard about it, is about how can do you think you can do in terms of pain assessment? Do you think you want to do something more in terms of assessment or ask something more based on today's session?
Yes, maybe we can rate the pain of the patient on different scoring systems. So we can have, based on a VAS score, or that we can assess that how the pain has progressed, because the patient might be feeling more pain, but the medications might have helped her. Not complete elevation of the pain is there, but there might be the VAS score may have shifted from like say 8 to 7 also. And over a longer period and with some emotional support, we can decrease the pain. With the family support also, the pain can be reduced. So we can get an idea that, okay, either the medications are working or not. They may have not completely removed the pain, but they are reducing the pain at a slower pace.
So do you think, yes, sir, please.
Yeah, I would like to say that here we can use actually patient's relatives and patient's moral booster, in a way that using a pain analogy scale, we can ask patient themselves that please rate your वो जो अपने smiley होते हैं, उसके basis पे we can ask the patient only that see yesterday you had a pain of up to 10 and now after the treatment you have a 9 or 8. So we can reassure the patient based on the result on analogy scale that see with the drug you are getting improved at least for the pain. So don't worry, with the management or whatever treatment is going on, you are going to improve. So this will boost up the patient's moral and ultimately help patients to come out early. This is one of the way we can help or counsel patient as well as their relative.
I totally agree to Dr. Chinmay. I think sometimes, as Madam was mentioning, the pain scale or the assessment is very important. Next time when you ask the patient may tell you, yeah, the pain has decreased, but we don't know how far it has decreased, how effective these medications are, or are they not at all effective? Do we need to change altogether, or do we need to step up the dose? Or are we on the right frequency? Are we giving? So for everything, this pain assessment is the key. Sorry. I think the proper management starts with thorough pain assessment at each visit. As Dr. Chinmay was mentioning, it's important to do that at each visit so you will understand where you have reached. Sometimes I will tell you that my pain has decreased, but it might be just 1 point decrease in the pain scale, where we might take it as, okay, the pain has completely decreased. So there can be subjective variation. So it's very good practice to do the assessment every time the patient visits so that we can give a good or reach up to a good management plan. Thank you, Dr. Chinmay, for telling that. And there are a few questions on who is the primary caregiver and the financial concerns. Do they have any financial concerns?
The patient is not from a very well-to-do family, but yeah, they have visited a government hospital. They are from, you can say, low socioeconomic status, and the caregivers are son and daughters. They are living with her.
And Dr. Sumita is again telling frequent reassessment and review in the treatment is the key. I totally echo to that thought. Because as I said, every time assessment is the key, and Madam was also mentioning reassessment, review. That creates a lot of difference in our practice in terms of pain management. And there are few procedures suggested by many doctors here. Dr. Roshan is suggesting the patient might have received multiple levels of analgesics, so radiosurgery might be an option. So there will be minimal requirement of analgesics and trigeminal nerve block with ethanol or bupivacaine. So Dr. Urmila is telling we need to understand the economic status before deciding on procedures. And I think one thing is we should also consider whether they have received optimum analgesia, or in terms of analgesics, have we reached the optimum medications? Are we choosing the right medications probably? Dr. Roshan is telling there are good chances patient may get pain relief by 80% in 1 to 2 months with minimal chances of recurrence. I think he's mentioning about the radiosurgery.
Just one thing, with the history what we have got here, her nutrition and emotion or the psychological element is very big. So if her nutrition being everything with the mouth thing, first thing we have to find out is if she's having difficulty eating, is she taking the medications properly? So these things we may be, this is an assumption that she's taking, but if she's having so much of discomfort, so then we have to think of syrup forms. There are so many alternative things for everything. So those are always in any pain management. That is what we just concentrate, or we get bytracked or bypassed that pain. The emotion, nutrition, those are all equally important. As I said, that's why the all other here main thing may be to find out how she's eating, what she's eating, whether she's taking the tablet every 4 hours. So she may be, if she's not at all eating, because many people have the assumption they will take tablet only when they eat something solid. She may not be eating solid, so she may not be taking tablet every 4 hour or 6 hour. So I know these are all time consuming, but in giving a little bit of importance to that and finding out. And then this emotional or that element, no, if she's so upset, she will miss or forget to take the tablet itself. See, if she's not having someone to take care, see, these are all like low mood effect where she may just skip. So that element, so some form of any other, or keeping her engaged in some way. I know these are all tricky stuff. in low socioeconomic, already they don't have any facility. So if she is otherwise active, we can encourage her to do something else. So those type of things, little bit of counseling and psychological support will play a bigger role. So if that is given, the medicine effect will also be an additive one. So here, I think those two can be considered with the nutrition, and every element is in the mouth and oral cavity. So she may not be able to eat and take the medications. We can see and then look at options like syrup forms or powdering and adding that to something else. So those suggestions could be given.
Thank you, ma'am, for that attention to details. We always talk about, we say that patient is unable to eat and then we don't know whether they're taking medications and inadequate pain relief. So thank you for that valuable point, that giving attention to details is mostly the key for better pain management. And Dr. Urmila is coming. Sorry, yes, doctor.
That might be a point that the patient is actually not taking medication and that's why the pain is not relieved.
Very true. So thorough history is very, sometimes the same thing happens, like we give all the medication and then the patient complains of inadequate pain relief and then they may not be taking the medications at all, probably. One time they might have felt some nausea or some drowsiness and they may not want to upset you telling that this medicine made me sleepy or something, so they just stop taking. Dr. Urmila has commented about opioid, which I am not taking up that in this session because we have a lot more discussions coming up on pain management. So probably we'll take it up then. So there is a question from Dr. Shatruba. Patients take medicines irregularly. Then how can we assess the pain control?
See, that is where like talking to them is so important. As I said, no, first we are like, even with, for example, when you start, I'm taking the example of morphine because normally it's used a lot. We have, I sit and I used to tell them, you have to take it 4 hours by the clock. Don't wait for I need to have something to eat. By the clock, 4 hours means 6:10, 2, like that you have to take. So you're not missing. And then anything to avoid nausea, we have to instruct them and get from the patient. No other, here only patient answer I will accept. Somebody else may say, but that person who is telling may be working. He may be in the office. And he'll be telling, oh, my mother is taking. Oh, who mother is taking or not, mother only has to say. So these, again and again, history, information from the patient. That is what will help. So I think that was the answer to the question of how we will know that and how we can assess. That's what you have to first make sure that the patient is taking. And if they are taking, in that time you cannot see. In for that also, for example, they take it at 6 o'clock and they take the next dose is for 10 o'clock. So from 6 o'clock to 10 o'clock, 6 to 8, how is your pain relief? 8 to 10, how is your pain relief? That will give you an idea how effective that, because you know bioavailability. When if it is taken orally, 45 minutes, you have to tell them, if you're taking orally, first 30-40 minutes, you may not feel any difference. After 30-40 minutes only, see, that's where pharmacokinetics, pharmacodynamics, everything helps for you to understand. So you ask the history from them. You take it at 6, you take it at 10. You will get a very vivid answer from them. Oh, so I used to even tell them, if, for example, they are so much affected by pain, I will tell them, you don't do anything that is difficult for you for the first 30-40 minutes taking the medication. Take the tablet. When you're reaching that 2-hour time, you have the peak effect. Even if you get up, sit, do something, do that time. You will have some comfort in doing it. So similarly, if you're going to do something, take the tablet, let it work in you, then go do something, so that to benefit. First, you're not upset that you're unable to do, and you're able to do. You being able to do gives them the courage and confidence. Next time they themselves will do. The whole problem is, oh, I can't, I am not able to do. I don't have the confidence that I will be able to do. So that is taken away by giving them instructions properly. So you tell them, ask from them when they took, And then in that period, in the period between first dose to second dose, how was their pain? That time you ask this code. Hope that
And
has
yeah,
answered
yeah.
that.
And
Dr. Sridevi, I think we lost her temporarily because of power outage, I suppose. Nice. Dr. Radha, are you able to access the chat by any chance? Ma'am, you are muted. Dr. Radha, you are muted.
I had just muted because I was thinking Sridevi is going to talk. No problem. I can access this chat. Don't worry. Okay. Next is I have got certain cases where the patients are very Suranjan Maitra. Okay. I have got certain cases where the patients are very much concerned about the adverse effects of painkillers. Yes, they usually come with pain complaints, but are of the thought not to take painkillers. Rather, they think alternative medicine are better. How to educate them in such case? Very good question. Okay, here comes the challenge. Fine, there are so many who don't agree. Fine, in that case, we don't say that don't go for any alternative. Fine, they can go for alternative method. But if they get pain relief, fine. But if they want to take this, I normally use a very good statement, which I will say. And if that works, well and good. In this world, there's nothing without side effects. Okay? It can be a side effect or an adverse effect. So most of them are side effects. Adverse effect is how you take it. See, for example, nausea you can take it as a side effect or an adverse effect. If you can teach them to manage that symptom, it is not an adverse, it's only a side effect. So anything comes with side effect. For example, the common statement which I say, I will tell you, even talking to your own friends and family, that has adverse effect and side effect. If you're doing gentle talk to what they like, that doesn't have side effect. If you're going to talk and say something which they don't like, that is side effect only. So in this world, there's nothing without side effect or adverse effect. So you have to tell them everything comes with it. Then comes risk-benefit ratio. Is the risk or the benefit which is more powerful? There you make the call. If the benefit is more, it is worth doing it. If the risk is more, don't do it. So this is how you will manage answering that thing. Are you satisfied with my answer, or would you? Thank you. So this is a common thing which we see, because people don't believe. But for even that, if they practically see and experience it, they will totally agree and come to your direction. So these are things, the risk-benefit ratio, you have to explain to them. So by being in pain, by being in agony, they've lost the day, they've lost their happiness, they've lost their comfort. Is that better than being pain-free? And once they enjoy being pain-free, they themselves will come and ask you for the medication. These are all practical. See, I am speaking only my 30 years of experience. Okay, all of you have that. So, and especially with cancer pain, because their emotion, everything is so low. 5 milligrams morphine. See, as Dr. Sridevi said, next 3 sessions, you're going to have all the WHO, different modes of pain management, everything. You will all become masters. Okay. So, but once you start them on that medication, you will see a different person in 4 weeks' time. For example, I'll tell you a nice example. There was a lady who had CA lung, and she was working full-time, I think. But suddenly with this thing, she was not at all able to do anything, from working full-time to not being able to do anything. So she was started on medications. And then first after 3-4 weeks, ma'am, I'm fine. I'm back to cooking. I'm doing everything now. What? Nothing, regular medications she started. Her cancer did not go anywhere. Nothing, no, 80% didn't change. But 80% of her life changed. So it is that, see, pain is so important. As I said, that's why pain and breathlessness are the big chunk. And both can be managed. Only thing, it has to be understood. It has to be done patiently. Time factor is there. And once you sit and talk to them and explain, most of them you say, oh, you have explained so well. Oh, what is in my mind? That is what, by seeing patients, all of you will gain and all of you know everything. So putting things in the right boxes and picking it up, that is what is important. So you explain and you don't force anyone on anything, okay? You just say, okay, this is what it is. You go home, think and do what you want. So to benefit in that, you're not forcing, okay? They are making the choice. Let them make the choice and they themselves will realize and they'll come back to you. Oh, you were right. Now I see the benefit. Also, then you're in safe boat. So that is the way forward. So it is possible. You explain to them, give them the risk benefit, everything. Tell them you make the choice. I'm not forcing you. You take your time, go home, think, and then do. Experience for one day. See the difference between, that is where this pain diary, another thing which we commonly use. Pain diary is something very, very helpful. Leave it to them. You tell them to mark a diary from day 1 to day 15. Before that, how they were. So before that, how much they slept, how much of confusion and worry was there. Then the pain diary will give them, you need not tell anything. They would have written and come, you just show them, oh, this is what you wrote, you see. So then, then they themselves will be, in that two benefits again, they will start having belief in themselves. You're boosting their own self-confidence. So many things, everything is important, everything is essential. So going in the right track, following everything will be helpful.
Thank you so much, ma'am. I got disconnected in between. Hopefully, we have taken up all the questions in the chat.
Yes. No
I can't
problem.
see no more questions. Are there any other questions from the participants? Either you can type again or you can unmute and ask before we wind up today's session.
The last one, being suffering from chronic pain, a doctor, how to not get personally while treating someone with pain and messaging personally. Yes, see, in that matter, being open, 8 out of 10 of us would have had personal experiences. I don't know whether to be open. I've gone through a lot of issues, like I've had major surgeries and things, okay? You have to have a very fine line when you're talking with the, may I know who is that person who has messaged that? Okay, fine. So basically, you don't be very personal, okay? But at the same time, you have to convey the message and you will be able to pick things properly. So you need not be personal in that, because if you're personal, it will only be harmful, okay? But when you gain a very good rapport with that patient, see, you will be seeing all these patients for years, umpteen years you'll be seeing. So when you get to a stage like that, when they themselves come, if you feel like if that is going to help in your rapport, you use it. Otherwise, you need not use it. There's no, see, personal and confidentiality are very, very important, because end of the day, all of you have to learn to take care of yourselves also. See, professional or occupational hazard is set for every profession. Our profession also has. So you also have to learn to take care of yourselves. You have to learn to dignify yourselves, at the same time take care of patients also. So there's no hard and fast rule that you should convey, but you should know to maintain where to say, where not to say, and these confidential issues, because always kept to its verbatim meaning, because it is good, safe for both of you and the patient. Okay, but you will understand stuff very well and it will help you. It's a general thing. See, that's why it said back pain. 8 out of 10 have back pain. So 8 out of 10 is a big number. So many will be in that 8 out of 10. So nothing to be of concern or anything like that.
I think maybe some personal pain experience as a doctor. Sometimes I use that to sensitize other doctors, like as a person, what we have gone through. So what happens to patients when they go through it. So that sometimes that really works because when we tell someone about someone's story, they think that it's just a story that these people are talking. So if possible, like from our team, if someone has gone through as a caregiver or as a patient, we just ask whether they are ready to share their experience. So recently we had an experience where Dr. Rajgopal was invited to talk about how it is to be like a patient's caregiver, what is the experience of a patient's caregiver to the final year medical students. So we actually took a caregiver. So we didn't take, he took a very short session and he asked the caregiver what they are going through as a caregiver. So that has a major impact on people when you teach. So I think in that way that might be helpful, where to share with your fellow professionals or students, like how it is to be like a patient on the other side of it, and what you would want as a patient going through pain. So probably some of them get sensitized. That's the only place where we can actually use it. Thank you, Dr. Parul, for
be a very good
sharing.
encouragement. It could be a very good encouragement, you know. I have had many people say, just friends and family, oh, we did not know so much information is there in this. So it's like an eye opener. It raises awareness in people. Okay, so they say, oh, we did not even know. They may be top shot in their own field, but they may not know anything. Oh, we would all love to know. Everyone has elders at home. Who is there not? And everyone wants to love and care. So this personal experience, that is why you see what I said. You have to find the fine line among professionals and things. It will be very helpful. It is something encouraging. I would say you will get more people to come and volunteer and help. See, everyone has time. Many don't know what to do. So little drops make a mighty ocean. Why can't we see why palliative care is so very minimal, scarce, not available? We have billions and millions of people in the world. For being a volunteer or anything, you don't need rocket science qualification. Humanness, empathy, all those, is that not in all of us? Can we all not help? So that is where you have to go and see. And so it is a little bit of finding the right place, being at the right time, right place, all that matters. So where you say, how you say, to whom you say. So if it is done correct, well and good. If not, again, it can go in the other direction also. So a little bit of identifying the right thing is what is important.
Yeah, Dr. Suranjan is asking about penning down and maintaining a pain diary is a very good option. But what about those who cannot write or maybe handicapped?
See, in that case, you get somebody like, that's what, if that person cannot write and do, if someone in the family can help. So that's what, see, these all socioeconomic status, educational status, they are all a little bit tricky only. So where possible, use it. If not possible, find an alternative. So, or verbally, that's why I say nowadays you have this option of telephone. You can just ring them and ask them. So when you ring them and ask them, you document.
Yeah, like we in our system, we do have nurses calling patients for review over the phone, because home care can be done only once in a month possibly.
Correct.
So they call, but they write it down like what exactly the patient told. Or nowadays everyone will have at least a normal phone where you can actually record the voice of the patient. We can tell what they're going through rather than writing it down. They can maybe just record and send. So yeah, I think we become innovative when you don't have options.
Exactly.
We became innovative during COVID, right? Who knew that
Necessity is the mother of invention here. That's why I said all of us have the capacity. We will all shine very well if we only put our heads into place. And then, as Dr. Sridevi said, I would say COVID is something you take only positive out of it. So much of online information. The world has become one platform today. I would say COVID was one of the reasons for it. So much of positivity we have got out of it. Yes, everything. Hindsight, you see, like science and technology, it's a double-edged weapon. Which end you use is what matters.
Thank you so much, madam. And thank you so much, participants, for these wonderful questions and sharing your thoughts without having any inhibitions. Thank you so much for everyone who have contributed to the chat, who have unmuted and spoke. And thank you so much, Dr. Parul, for sharing your personal experience with us and others for giving the feedback on the session. Thank you so much, ma'am, for once again coming for this session. And she's with us taking these sessions for quite some time now. And every time we also learn something new from the participants, or we also start thinking in many new ways after each session. I also learn something new after each session. Thank you so much, everyone, for the participation, and thank you, ma'am. Shripriya.
Thank you, Dr. Radha. Thank you so much. Enlightening, as expected, always. Thank you so much. And thank you everyone for joining in and making the session very much interactive. And as promised, we will see again tomorrow with another interesting topic and another eminent faculty. Just a reminder that tomorrow we will be moving on to the management of pain section. So please make sure you don't miss the same. With that note, this is Shripriya along with Dr. Radha Venkatesan and Dr. Sridevi Warrior signing off from the Tips Eco Hub. See you tomorrow. Take care. Bye-bye.
Thank you, Vanan.
Thank you, ma'am.
Good luck to all.
Thank you.